This conference will now be recorded.
Okay, Sally.
Okay. Well, welcome everyone to our cohort discussion for today in terms of the framing rural health value. And if we can have the slides pulled up, please, Nicole. Thank you. Great. Our discussion today will be on processes for improved financial and quality outcomes and data measurement outcomes and impacts. So we're actually looking at three pieces of the framework today. And our objective is to go have a discussion around the third application exercise of application of critical success factors. And we'll be asking everyone to share examples of their states that they have used in these areas that can be some best practices. And our learning objective, again, is looking at, through our case study, Critical Access Hospital, is developing group recommendations for improvements in those areas of finance and quality outcomes and data measurement outcomes and impact. So to get started, how about we we'll have everyone introduce themselves and just share what states and Flex program you're with. And I'll just, it's *2 to unmute, and I'll just call people alphabetically by last name. So I'll start with Angie.
Hi, good afternoon, everyone. I'm Angie Allen. I am Director of the State Office of Rural Health and also the Flex Coordinator for the state of Tennessee.
Thanks, Angie. Jill?
Hi, it's still morning here in Arizona, but good morning. This is Jill Bullock with the Arizona Rural Health Center for Rural Health. I am the Rural Health Coordinator for Arizona Center for Rural Health and the Flex program.
Thanks. And Joyce?
Yeah, I'm just also with the Arizona Center for Rural Health and Manager of Health Systems and work on Flex, SHIP, and SOAR.
Okay. Thanks. And Christy?
Hi, this is Christy Martinson. I'm with the Federal Office of Rural Health Policy. I'm the Hospital State Division Director and currently the Interim Flex Coordinator.
Thanks, Christy. And Maeve?
Sorry. Hi, this is Maeve from the state of Oregon, and I do the Flex, SHIP, and SOAR grant.
Thanks, Maeve. You probably need to mute your computer because it might be picking up the mic there too. And thanks for calling in. And are you still out in Rapid City? Okay. Well, what we'll be going through today is just a review of the framework and the sections we're looking at today, and then discussing the exercise in terms of the interventions and all of your recommendations, and we'll look at a summary from that, and then share some best practices. And our framework, which is becoming familiar now, in the areas we're focused on in today's cohort are in the purple, pink, and green, looking at impact and outcomes, and also the processes for those improved outcomes, which often include financial intervention and looking at improving practices around revenue cycle management or in collections and cost report review. And then finally, measurement, feedback, and that knowledge management of having a feedback loop to review the data and then impact the other areas again. And that measurement, feedback, and knowledge, it is looking at the evaluation and the progress and then utilizing the tools and resources. And actually was the focus of our workshop earlier this week on evaluation. And in the processes, that tends to be the processes such as lean or plan, do, study, act process or CQI. And within a hospital, that could be very specific to things like team steps around patient safety. And the impact and outcomes for a hospital are really important, that they are looking at their benchmarks and the impact then that they've made in terms of the overall community health and the value of that hospital to the community and the value in terms of quality and cost for the patients receiving care and being able to communicate that value. And that's where we often see with hospitals that they're reporting the information that's required, but maybe they're not bringing that down to communicate that value back out to their patients and their other stakeholders within the healthcare system and even their own board members and employees. And just to review, before we get into our recommendations, we'll look at the case study of Community Memorial Hospital. And the hospital, as you recall, was a CAH that was without a CEO and was under the leadership of a newer CFO. And he's been with the hospital for just 18 months. And they've been having a lot of turnover in nursing. The HIT skills are not extremely strong. And in the financial, which we'll be reviewing today in terms of interventions, they've had a lot of struggles. They only have 12 days cash on hand. Their average accounts receivable was double the U.S. average of 53. Their operating margin was negative 4.5. They haven't updated their charge master. And they, in terms of process, they were participating in MB-QIP, but they don't use any evidence-based practices. And they don't have a formal patient satisfaction process. So that's just to kind of remind us all where they were at with our case study. So our exercise, the questions we'll be looking at is what type of intervention you all recommended for Community Memorial Hospital to implement for process improvement, for financial and quality outcomes and data measurement outcomes. And then we'll get into why folks recommended certain programs and maybe how you would implement that or support that from your FLEX program. And then finally, we'll talk about if folks have implemented any of these higher recommendations and what kind of results they've had. So we'll Nicole's bringing up the summary, and this is for our Cohort D, which includes some folks, obviously, who can't be on the call today. But the top number of points were assigned to exploring partnerships with larger systems or rural health networks, such as facilitating network activities, care transition, and data sharing. And then the second most highest was using a systems framework, such as the Performance Excellence Framework, to manage information and strategic knowledge. And why don't we go around and we'll just have each of you share what you had listed as the top points for interventions for this hospital in these areas, and why, and you know, how you think a flex program could support that. So I'll start with Angie from Tennessee, and again, star 2 to unmute. And Angie, which one did you rate the highest? Okay, we still can't hear you, Angie. Is it star 2?
Can you hear me now?
Yeah.
Okay, I'm sorry. I guess I didn't do that successfully the first time. I apologize. I was just talking, and y'all could hear me sometimes. But at any rate, the question was, which one did I rate the highest?
Yeah.
Was the question? Okay. There were two that I rated equally high, and both of them have to do with multi-hospital network quality-focused interventions, and that is supporting a CA and a multi-hospital network quality project focused on financial and or quality improvement, and also the same with measurement and benchmarking. So those were the two that I selected. I felt like the issues at hand here with this particular hospital, of course, are financial, but quality is also an issue. And considering the fact that you have leadership that doesn't have a lot of bona fide leadership experience. They have a lot of hands-on experience, and as we've talked about in previous calls, a lot of the times you have practitioners that are very skilled and astute in what they do in terms of direct patient contact, and then they're promoted to a position to where that skill set shifts to having to be able to direct, lead, carry out a strategic plan, work with staff, which is a human resource element. All those things require a totally different skill set, and the training is not quite there. And I felt like because of the quality issues with the word out in the community, that the hospital has some areas or opportunities for improvement in that area, that networking with another hospital that in particular has credibility in these areas or has the resources that they could share with this hospital would be the most cost-effective way and the best way to get the quickest results and best impact. So it's sort of like the concept of value-based purchasing, where you pool your resources, or also with ACO. You know, everyone works together utilizing the same, they're working from the same pie or the same pool of resources in order to be able to carry out activities and save money in the process. So that was my rationale behind picking those two.
Okay. Okay. Great. Thanks, Angie. Okay, Jill.
Hi, Joyce and I worked on this together, so we wouldn't include two of our opinions, but
Sure.
We rated exploring partnerships with larger systems or rural health networks as our highest. I thought they needed a lot more. They need a larger systems to back them, to give them resources, I think, to survive. And unfortunately, we're seeing that in one of our hospitals right now. And for the second one that we rated was providing or arranging for direct technical assistance to CA via technical experts on finance, business processes, quality of care, and patient satisfaction. I wanted to rate that almost as high as the first one, exploring partnerships, although I felt that, or we both felt that exploring partnerships really needed a lot of the numbers towards that one, so we rated that one a 2. And then the third one was providing CAW leadership development and management education support to improve overall CAW performance. There are more in here that we certainly could have rated that they needed help, but I think personally, and just seeing what other hospitals are doing, they're exploring the partnerships to get the buy-in or to get the resources with their health information technology systems that are expensive. We're seeing more and more hospitals do that, and they're more successful that way.
Okay. Great.
That's it.
Thank you, Jill and Joyce. Okay.
Or Joyce, do you have anything to add?
I was curious how, as
Yeah,
a flex
yeah, I
program,
can add just
you
a
would.
few. Huh? Oops. Sorry.
Well, I was curious how, as a flex program, you would support a CAH, and you said you have one in this situation. How would you support them exploring those partnerships with a larger health system?
Well, the one that is in that I was sort of referring to was just bought out by an People's Choice. They have been bought out, although they're still struggling to succumb some of the Medicare audits and things like that. So I'm not sure I can answer that question
Yeah,
to how you want it, because they have been bought out.
right, but we have offered our services in whatever they feel is the priority, and so that's sort of in the works to say that we can provide them technical assistance on some issues that they're dealing with, and so rather not really go into the detail on that, but yeah, I mean, Jill highlighted what we thought. I mean, there was so much, even with the weakness in the leadership there, that in order they had to get over in the case study, they had to get over so many hurdles there that for them to survive, they really needed to get with somebody who had a reputation, who had, like Jill said, the resources, and then really then hone in on their employees to get them involved and more in tune to what's happening out there. But yeah, it's it's a challenge. But well, as an example, I mean, it's not necessarily a critical access hospital, but what we see is happening just within our community is all on this, population health management. How do you come together? Carondelet Holy Cross in one of our hospitals. Carondelet Holy Cross is part of Carondelet Health Network here, and we just saw just yesterday it was announced that their Ascension Health Hospital, and they're going with Tenant and Dignity Health, which is here in Phoenix, and Ascension Health, a three-way partnership. And my question was, well, what's going to happen to our critical access hospital that's part of Carondelet? And so it'll be part of that, but we know that Carondelet's been struggling, and so we see it just yesterday on what's happening in the state of Arizona on hospital systems coming together. Banner Health has just taken over the management of the University Medical Center. So I mean, so when you see a case study like this, it's huge of how you have to come together and spread the resources.
Right.
You can't do it alone.
Right.
Right.
Okay.
I'm curious to know, this is Jill, I'm curious to know if this is really, if this is happening all over the country, or if it's happening a lot in Arizona, because there was another hospital that we heard that Banner was going to take over, which was one of the critical access hospitals.
Yeah. In this region, the Midwest, I haven't seen that there's been an uptick in. It's more, I think, even of kind of stepping back and not doing. Even though the bigger system may be offering access to an electronic health record or assistance with data, analysis that they're not necessarily moving in and taking over everything. But that's the Midwest. I don't know, Maeve from Oregon, are you seeing changes?
So in Oregon, we actually have not seen a lot of system takeover. I think we have, out of our 24 critical access hospitals, I think we have maybe I think 3 different networks that work with our critical access hospitals. The number of hospitals in those networks, I think we have 3 in one network, 2 in each of the 2 other networks. So really not a lot of network takeover at this point.
Okay. And Maeve, which intervention or 2 did you rank the highest?
So my top 2 were actually developing more leadership. I can't remember. I apologize. I don't have my sheet in front of me. I'm sitting in the hotel room on my other computer right now. But I said developing the leadership and then also evaluating the strategic process and regularly checking in with staff. One of the things that really stood out to me reading through the case study was how much it reminded me of one of my jobs as a clinic administrator, where it was a small rural clinic where we were lacking an executive director, and just there were a lot of great people involved in the organization who really wanted to provide quality care and increase our patient base, but everybody had great ideas, but they were all different ideas. So I guess from that early experience, I always really focus on kind of what's the capacity to adapt, change, and where the leadership is going, and also making sure that you're harnessing kind of everybody's enthusiasm and suggestions. Like I think in the case study it said that there were staff who would kind of voice these opinions that felt like they weren't being listened to. So I focused on evaluating the strategic process and sharing the information organization-wide so that everybody would feel included to hopefully help with retention, reduce turnover. Because I think when staff really believes in what the organization is doing, that projects better to the community and comes through in things like HCAP scores. And then also just making sure that there was enough leadership capacity so that, everybody kind of team steps up where everybody felt like they could contribute and to ultimately really build capacity in the organization. So those are my top 2.
Okay, great. Okay, thank you. And Christy, do you want to any comments on intervention?
Well, the one that I think, they needed both quality and some financial assistance as well. So the top one for me was providing or arranging for direct technical assistance for the CH around particularly the financial issues first, and then getting involved in a rural health network or a multi-hospital quality project for the quality issues.
Sure. Okay. Great. Good. And it, I think the one that ranks third that none of you mentioned directly, so maybe it came in from some of our other participants, or that you still gave points to, but just not first or second, was developing a workforce that's change ready and adaptable, and certainly that would get into the creating a stronger culture that's engaged in quality, and as well as trying to make some changes in their process improvement and the impact, long-term impact in quality. And with the interventions, like to just look at, if any of you have implemented specific flex interventions in these common areas of helping rural health, supporting rural health networks or facilitating network activities, or in the looking at the process improvement, things like Team Steps, Baldrige Lean, the AHRQ surveys. How about Angie in Tennessee? I know you work closely with the hospital association. Have either of those areas? It's star two to unmute.
Can you hear me now?
Yep.
Okay, I'm sorry. Okay, but while I was in the process of unmuting my line, there was a lot of bleeps and tones and that sort of thing, so I caught bits and pieces of your question. You were asking about, I caught the tail end of a question pertaining to activities with the hospital association. Did you repeat that?
I wondered if you've used interventions around Baldrige Lean or patient safety team steps or network support, either through your office or with the support of the hospital association through the FLEX program.
Sure. I think the best place for me to start is just to give you a schematic of the hospitals in Tennessee and the type of support that they have available to them. And we have several of our hospitals that are part of a bigger healthcare system. And because they are part of that system, they have resources available to them through that system. And as a participant in the FLEX program, FLEX comes in and helps to supplement where support is needed. So we do have critical access hospitals that are participating in team steps and patient safety culture surveying and that sort of thing through support from the hospital association. The other thing that I'd like to mention is that we do have hospitals that are not part of a bigger system, and those are the ones that rely upon FLEX support with more emphasis on being able to take advantage of direct consultation in terms of financial intervention. And so what we've done here in Tennessee is we had identified about 7 of our critical access hospitals using iVantage because we do participate in that program, but through feedback that we receive from the indicators that are part of our Advantage reports, we were able to identify several critical access hospitals that appear to be the highest on the list of being financially vulnerable in the state of Tennessee. And it just so happened that the majority of these critical access hospitals were those that were not part of a bigger system. And so what we decided to do was just to invest the individual interventions for each one of those hospitals. So we partnered with Statewide and asked them to come in and do a one-on-one consult with each hospital. And from that, we were able to receive critical access hospital financial and operational assessments for each one of these hospitals and able to identify the specific recommended interventions for those hospitals. And some of them have already implemented those interventions and are seeing results right away. We had one hospital, and I apologize, I don't have my notes in front of me, but we had one hospital that followed through on a recommendation and was able to see a financial gain of approximately $100,000 after they pursued that intervention. And this hospital was in very bad shape financially, so that's the direction that we're heading in. Now, in terms of Baldrige Lean, team steps, those sort of quality interventions, those are in place, like I said earlier, with the hospitals that are part of a bigger system because that's usually the pivotal direction that most of those larger systems are going in. They're headed in the direction of using those resources. And with the hospital association that has both a Center for Patient Safety and also THA as a hand, all the critical access hospitals can take advantage of the different types of quality improvement tools and benchmarking reports that are available to them at any time.
Okay. And how's the participation been from the CHs in the HEN activities?
Well, we have critical access hospitals, again, going back to those that are in a system, their systems are associated with their particular HEN. For those that aren't in the system, they have the option to participate with the Tennessee Hospital Association HEN, and they take full advantage of that. The overall answer to your question is that we have great participation it just depends on which hand the hospitals decide to gravitate towards. But our hospitals do see the worth and the value of engaging and connecting with whatever hand they're affiliated with.
Okay, great. Okay, thanks, Angie.
You're welcome.
Okay. And then in the Arizona, Joyce and Jill, either you have a success story or two that you'd like to share around either the process improvement support for CHs or network facilitation, network development.
Well, this is Joyce. I mean, we have several sort of networks floating around in our work, one of which is around level 4 trauma. And 8 of our 15 critical access hospitals are level 4 trauma. And just last Friday, we had the second of a 3-part series of the level 4 trauma managers, and it's statewide. It's not only our flex, but working on 4 indicators that have been developed through the combination with the Bureau of EMS and strategies on which to improve dwell times as one of the major indicators. And so this is a process now that's been going on for about 3 years. It's evolving. It's really seeing some success, being able to share best practices among the level 4s that are larger than in the cause. So it's really a statewide initiative that is really taken on just such steam. I am just so thrilled about it because the level 1s and the level 3s are also part of this, and how coming together to help the level 4s in these small rural communities on how to put in best practices on how to figure out what it is that you can improve that as an example of the dwell time. So that's just one example where we've honed in on something that we feel for the size of our state that trauma is key, and the relationships that we have developed statewide along with the trauma 1 and trauma 1 level and trauma 3 level and the 4s has been pretty exciting. And so this whole performance improvement process and plan is it's evolving, and our next meeting is in November for the next part of the series. So that's one idea that we're doing here, and Jill has a few others I'm sure she'll share.
Okay.
I think we've set up listservs with all of our networks, and they have shown to be really effective way of peer-to-peer working, bouncing ideas off each other, and just staying in communication. And I didn't want to be listserv heavy, but they seem to all love it. And so if other flex programs don't have listservs, I would highly recommend that you do that, especially if you're a big state all spread around. But the Level 4 Trauma Center is probably our biggest used listserv, and there's so much activity on that, and you can just see the excitement and the energy in that network. I just wanted to add that to what Joyce said, and that no other, as far as we know, no other states are working with their level 4s and their level 1s like Arizona is, and it's pretty exciting to see this process and how they all come to the table with so much energy and willingness to learn and take that back to their hospitals and implement these plans.
Yeah, and with that, I mean, just as an example, last Friday, I mean, we had 2 trauma surgeons that came and just talking to everyone and engaging these trauma surgeons around the state it has been, really tremendous. But Jill, I don't know if you want to talk about what you've done with your quality group because of their focus on HCAPS and patient satisfaction and getting some sort of common things, projects that they're working on.
Yeah, sure. Our quality network has been focusing on the patient experience, and with that, with critical access hospitals that didn't already have their HCAPS, we supported some of the startup fees for getting HCAPS, and then we asked that each of our hospitals choose a project to work on within HCAPS, one of the questions. So our three most popular ones that our hospitals are working on were pain management, quiet at night, and what was the third one? I can't remember offhand. And then we've been asking for their HCAPS data monthly, and I've been tracking their scores and their progress. They all provided me with an AIM statement, and within that AIM statement, they also had a date that they needed to reach that goal by. And so then we've provided tools to help them reach those goals. So we gave them Studer books on HCAPS, and then we had a consultant come in that gave best practice tools and other forms of tools to improve their HCAPS scores. So that's our quality network.
Oh, okay. Great. And Maeve, I know you're newer to Oregon's Flex program, but is there a
Yeah, I actually, before I share about what's going on in Oregon, could I actually ask another question about the HCAPS measures in Arizona? Because actually, quiet at night and pain management are two of the areas where we're kind of struggling with our MD-QIP. And specifically on quiet at night, I mean, like, I feel like for healthcare quality, there's a lot of tools. Are you able to share a little bit more about kind of what those tools look like that you use for things like quiet at night, or any suggestions?
Sorry, I was unmuted. We just did a webinar, and I've got all kinds of resources that have quiet at night tools that I'm happy to share with you. Do you want me to just email it to you, or email it to the Flex Forum, or how would you like?
If you could email it to me, I would definitely appreciate that.
Okay.
just
Yeah.
you can CC the task, and then
Okay.
we can post it on the forum if that's okay with you, and we can share it with others.
Sure.
In the quality forum. Okay.
Okay, that would be great.
And this
Perfect.
is Joy. What's so interesting about that whole thing about quiet at night is that how in the discussion of the quality group that it was that it's quiet all the time, and how that sort of expanded, then not just at night, but what happens during the day. And that was just an aha for me as the conversation went just last week. I think it was Jill, that it was like they're focusing on quiet all the time.
Well, and also
how noisy things get.
But also that the quiet at night is mixed in with the hospital environment, the cleanliness of your room. So the interesting thing is that their cleanliness scores went up because it's grouped in with that one, even though they're completely different questions. So I thought that was pretty interesting.
Yeah, that is. Thank you. I really appreciate that, and I'd love to see those resources. That's definitely something we're hoping to go. But kind of moving on to what is currently going on right now is we obviously don't really have many systems, but we do have kind of two networks that we work with, and one is the Hospital Association. I think we've been working with them for 3 years now, and they run our Partnership for Patients group, and I think we have most of our critical access hospitals. I think about 2/3 of them participate in that, just looking at patient safety, and I can't remember what the specific issues are off the top of my head. So we have Partnership for Patients through the Hospital Association, And then we also have our Oregon Rural Health Quality Network, and they work on a lot of team steps training. And I think they're kind of going through with healthcare reform in Oregon. I'm sure you guys have heard a little bit about the coordinated care organizations and how that's kind of changing the service delivery. And so part of what we're going through in Oregon right now is renegotiating, you know, who's in what network, how many networks they are, and kind of where they're working together rather than overlapping. So that's part of what I'll be figuring out in the next month or so. But for now, we mostly do that network work through the Hospital Association and through the Rural Health Quality Network. So.
Okay. And I think Susan Trigg from Virginia, welcome. I think I'm seeing you're on the web portion now. So I apologize. I missed you on the last round. We're just talking about looking at some of the main, most highest ranked recommendations, especially around facilitating network activities for CHs and then offering process improvement. And just wondering, in Virginia, if you've done either one of those to share a best practice or success story.
We're working on success stories.
Okay.
We're doing new things this year with this during this grant year, and networking is one of them. We have 7 CAWs, and now we have we find this year that we have 2 of our SHIP hospitals that are wanting to convert to CAWs. One of them closed in 2013, October, and the community got together and developed a health authority. They started a health authority, and they're reopening that hospital as a critical access hospital. So that one, and then another hospital is, you know, going to critical access status, which is really good in one sense because the other hospital is in a part of our state where there are no critical access hospitals, but where there is a great need. So it has a way of working itself out. We've developed 3 things. We have a multi-state network that in the quality area that is, you know, sort of working, kind of. Mm-hmm. We are trying to figure out exactly what that has been doing over the years and move it forward onto a new level. We also, in core area 2, at the end of August, somewhere towards the end of August, middle to end of August, we're having our first Southeast Regional Critical Access Financial Improvement Collaborative. Long name. I hope we change it during the meeting to something that's a lot shorter. But we're hoping to, we're working on bringing together North Carolina, Kentucky, Tennessee, West Virginia, and Virginia critical access hospitals to talk about financial operation issues and share information, talk about best practices. We have one critical access hospital that is independent, so we hope through this process that they will be able to network with other independent CAWs in other states, and through that, learn some things and share some information. It is a sharing of knowledge, a building of a database of knowledge, and just strengthening the critical access hospital in this region, the whole cohort in this region. That's our hope. That's our goal. We don't have a success story yet because we haven't done it, but we're working on it. Okay. We also have started a critical access hospital coalition in Virginia. We, at the time that it started, only have 7. We could have 9 coming up. But the one thing we heard from our hospitals was that they felt alienated. And so we wanted to bring them together just to talk to each other. We just had our 3rd meeting. That's been very successful in terms of the sharing of information. One thing that happened that we were surprised about was that because I'm a learner, I probably shouldn't have been surprised, but I'm a learner. I'm new to this position as of March 2013. So when we had our second meeting and the hospital systems people came, that was really exciting to me. I was probably the only one that was excited. But it means that we're able to discuss things that affect hospitals that are not in Virginia, that are part of that hospital system.
Right.
So, that's really good. So those are the things that we're doing around, collaboration and networking at this point.
Right, right. And when did you say that multi-state meeting is?
Right now it's scheduled for August 19th in the far western part of the state, so that we're closer to where the other, it's kind of like in an area where all the other states can easily come without having to travel a great deal. We're running into conflict, though, with the NOSOR Region B meeting. We're currently part of Region B. That's going to change in the future, but this meeting is, so we're working out the details at this point. But our critical access hospitals are really excited about it and on board, but we want the other states to attend, so we're changing our processes, trying to figure out how we can accommodate at least the most people, which is always a difficult process.
Yeah. Okay, good. Well, thanks, Susan. And I'm just curious, and for the rest of the group, which one of the interventions did you rank the highest?
I'm embarrassed because the whole ranking is very different from what I said. I ranked the highest using a systems framework to manage information and strategic knowledge. That was my highest one.
Well, from our summary of our whole group, that received 9 points. So that was
But the rest of them were pathetic. I mean, they weren't even on the summary, so I won't talk about them.
No. Well, thank you, everyone, for sharing some of the things you've tried or are working on around these areas and best practices. And I think in the discussion we had a few mentions of hospital turnarounds, and certainly this CAH, which Terry says is actually based on a real hospital he's worked with, that is still open. But I wondered if anybody else has a turnaround story, where there were a lot of financial or process improvement issues.
Well, here from Tucson, stay tuned.
Mm-hmm. Yeah, you were mentioning.
Yeah, no, we're in the midst, so stay tuned on that.
Mm-hmm. Okay. Anybody else in Tennessee or?
This is Susan. I just have a question for everyone. We're running into something with our hospitals that's really surprising to me, not with all of them, but just 2 of them. Our Virginia State Rural Health Plan is a community engagement process. So through the core area 3, we are implementing the rural health plan, the state rural health plan, as part of that process, and engaging the critical access hospitals, EMS, and the local health department. And we decided to, put out a mini grant memorandum of agreement to the critical access hospital with very simple deliverables that, come from their community health needs assessment and our Virginia State Rural Health Plan and their strategic plan. So it's really a matter to complete the community engagement template that I've created, and the population health management document from National. But in order for them to complete that template that I created, it's just a matter of cutting and pasting information that they already have. So it's no work for them, and it's a small grant, but we wanted to, jumpstart our Virginia State Rural Health Plan. We have 2 hospitals that suddenly are, at the Call Coalition meeting, everyone was on board. They were excited about it. The fact that the hospital would be in charge and calling the shots for the community engagement plan. And now, almost a month later, we are, with 2 hospitals, running into difficulty where they don't seem to understand, and they're very suspicious of the process. That's what's surprising to me. Suddenly they're very suspicious of the process. What we've done is develop a statewide community health advisory board, and that board is made up, we started out with 10 people, now we have 21. And we have as a partner a governor's advisory, a governor appointee person who is in our office. And, she got people on that board that's really, and they're going to look at the plans. They're going to make recommendations. I'm developing a template, an evaluation template for them. And I can't figure out why these 2 hospitals are now backpedaling. And really, one of them has already said, we don't want to do that. It's our only independent hospital. The other one is part of a system, and I'm not sure what's going on or how to even deal with it. Does anyone have any thoughts?
I was going to say, we're doing a similar project in Oregon where we had a lot of hospitals that were pretty much set on community needs assessments, and so we introduced a grant program to help them actually implement some solutions to needs that they identified. So I don't know if I'm understanding correctly. It sounds like that might be kind of similar to what you're doing in Virginia. One of the things that we did, which I'm not sure if it helps you at this point, but it might help you in the future, is we made all of our hospitals write their own grants to kind of filter, because we had that issue too with hospitals pulling out, where we originally had 4 hospitals that were really excited about working with us, and then there was one who submitted a proposal and it wasn't exactly what we were looking for, so we then kind of asked them to revise some things, but we were still going to fund them. And at that point, when we asked for the revision, that's when they totally pulled out, even though they've been really enthusiastic to that point. So I don't know if it was a matter of the hospital just kind of not feeling like they had the capacity to do the work. But I think it did help us in the beginning that we actually had the hospitals kind of write their own grant rather than making it easy for them, I guess, because that kind of cut out some of the hospitals who from the start wouldn't have had the capacity to do so. So I'm sorry, that's probably not helpful.
That's very helpful.
That you have right now, but for the future, maybe. Yeah, it's a challenge.
Thank you. That's very helpful information.
Oh, good. I'm glad.
Other suggestions for Susan? Okay, good. Well, as we're wrapping up this case study for this hospital, and we're hoping it turns around with the interventions, what task will be doing is taking the summaries from all the cohorts in the from the last 3 sessions that we've had around the assignment, and developing like an overall intervention plan, and we're going to, as a team, then work on, well, what were the outcomes, potential outcomes, and the impact of those interventions for this critical access hospital. And I think hopefully this has helped you see, even if there's, this hospital, we deliberately put in many, and made sure we emphasized all the different areas. But even if it's a hospital with a primary issue around financial distress, it still takes a holistic framework in terms of how you support that hospital, and if it's an intervention that maybe is just looking at their data and not helping them with that leadership and planning piece, or seeing where, addressing the financial data also, needs to come into those other components of the framework. It's probably not going to be a long-term impact, or that the recommendations will be fully adopted by that hospital. So again, to wrap up, we have one more plenary webinar to complete our series and break through the tape on August 11th from 2 to 3. And we'll be, again, sharing the summary of the cohorts and